Hello from Boston. Today we're with Dr. Dale Adler, who is Professor of Medicine at Harvard Medical School and Executive Vice Chair, Department of Medicine at Brigham and Women's Hospital in Boston. Dr. Adler received his MD at Weill Medical College at Cornell University. He did his residency in internal medicine and fellowship in cardiovascular medicine at Brigham and Women's Hospital in Boston. Dr. Adler's clinical and research interests are in cardiovascular disease, specifically complex coronary artery disease, diabetic heart disease and its prevention, and valvular heart disease. Dr. Adler also has extensive healthcare organizations and integrating hospital networks. Dr. Adler, thank you and welcome.
Thank you very much for having me.
Let's start with valvular heart disease. My mother had mitral valve repair at Brigham and Women's Hospital several years ago, so from a patient perspective, I learned just how intricate and how well timed and choreographed the whole process of managing valvular heart disease has to be in order to benefit fully the patient. But not everyone needs the surgery right away. So what is the role for medical cardiovascular treatment in valvular heart disease, and how it's best to prepare people for surgery and manage them in postoperative period from a cardiovascular standpoint?
You're asking a very interesting question in the entire realm of cardiology. And if we talk about mitral valve repair, you have to realize, and I'm sure you do, that 2.5% of males and 6.5% of females in this country have mitral valve prolapse. And in fact, if you examine people, and this was done many years ago with young people coming into college, and people did a careful listen, and they said, my goodness, 15% of these people have a mitral valve click. Now, there's 15% who have a click, but like we said, the numbers, 6.5% in women, 2.5% in men, are much lower for who actually has real mitral valve prolapse. But the real numbers are that out of all those people, 90% of them will do perfectly fine throughout their lifespan. And it's really only 10% of those people, so it's becoming a progressively smaller number, who actually will really need attention to their valve. And so whenever we meet patients, take a good listen, realize they have mitral regurgitation, they have an echocardiogram, you find out, yeah, they have what we call classic mitral valve prolapse. The leaflets are thickened and there's some amount of prolapse. The leaflets open perfectly, they move from exactly where they're supposed to be, open up nicely, but when it's time for them to close, one or both of the leaflets will bow backwards into the top chamber of the heart on the left side, and there'll be a leak. Most of those people aren't going to need anything done over a long period of time. And so the group you're interested in always is the group that's symptomatic. Of course, if somebody says they're short of breath, or if they're fatigued, struggling, we're interested in them. Or if they have a leak that's severe enough so that over time we're realizing that their heart chambers are enlarging. And along with the enlargement can sometimes come an increase in the pressure in the lungs, and sometimes when they stretch the top chamber of their heart on the left side, they could start to have rhythm disturbances. So that's really the group we're interested in. Now, your question, how can you prevent that? Are there medical solutions? Probably one of the most important lessons we've learned over many years is that if that process is going on, so the leaflets are prolapsing more, they are having a harder time keeping the blood moving forward, the chambers are starting to stretch, then it's a mistake to try to use medicine to manage the people. So we could use diuretics, we could make the heart a little smaller, we could use ACE inhibitors, unloading agents, make it a little easier to allow the heart to pump the blood forward, and a person might feel better. But even though they'll feel better, that underlying process with the heart stretching, getting worse, will still be going on. And it's been shown very nicely that if you are doing that, if you're treating a bad valvular disease medically, you're not doing the person any favor at all. Eventually, they just get worse and worse.
So in other words, if there is a mechanical problem in the heart that's been identified and there is evidence, presumably by echocardiography, that it's getting worse, as well as by the clinical examinations, the most important thing is to focus on treating the mechanical problem, and then only after that to give a medical support to the heart.
Correct. And one caveat, one area to be careful. So you can have somebody who has what seems like very severe mitral regurgitation. They feel very well, and their heart isn't stretching. And it always is very nerve-wracking to say, oh my goodness, there's a severe leak. They feel fine, their heart isn't stretching, the pressures in their heart are good. Shouldn't we correct it? And there's a lot of discussion. And in this country, when people write guidelines, what they say is, well, if it's a severe leak, even though a person feels fine, even though the heart isn't stretching, if you're very sure you could repair that valve and repair it very safely, then it's okay. It's okay to go ahead and consider repairing it. And I think we just have to be very cautious with that approach. So with what you said, I would just add, in addition to the severe mechanical problem, something else that shows you the way the heart is integrating it. The heart is integrating it in a way that tells you the heart is suffering, then absolutely it's a mechanical solution. Don't try to use medications for it.
How do you prepare people for the surgery, and what are some of the key aspects of managing people after the valvular heart surgery?
In terms of the preparation before surgery, it really is the same for heart surgery as it is for any surgery, as it is for almost any stressful circumstance in life. We would love for people to be fit. So if they've been a smoker, it's an extreme help if they can stop smoking for at least 6 or 8 weeks before.
And even 6 or 8 weeks makes a big difference.
Makes a big difference. You're absolutely right. And if they've been inactive, it makes a big difference if they're just a little more fit going into the surgery. Now it's tough because if they have valve problems that are severe enough so that they're creating shortness of breath, you're probably not going to be able to get somebody really fit during the course of that time. But those are really the only kinds of things that you could hope that you'll be able to accomplish before surgery. In terms of after surgery, if a person's surgery is done at a time when they had the appropriate symptoms and they were just starting to show some heart problems, but just starting to show them, repairing the valve will make them feel better very, very quickly, and their heart will have plenty of reserve. And sometimes it's a beautiful story. On day 3 after surgery, even though people have discomfort from the surgery, they already say they feel better. So that's a wonderful group. And it really doesn't take very much following surgery to take care of them. Then, of course, you have many more people in whom just the procedure itself has been a real stress to their body. They're more tired, and it just takes time. So we usually say it takes about a month to feel pretty good. We usually say by 2 months, we're hopeful you're going to feel terrific. You're going to realize, oh, I'm much better than I was before.
It's probably very gratifying to see patients who have not been probably doing that well before and after the surgery, just, they fly.
Well, it's wonderful, and you know, as a physician, that's really your goal, and nothing makes you feel better.
Atrial fibrillation is one of the most common arrhythmias, and it's also commonly associated with heart surgeries and also in thoracic surgeries in general. Treating atrial fibrillation often requires anticoagulants, which are associated with significant side effects such as hemorrhagic strokes or significant bruises if somebody falls. So it's not an innocuous treatment. Who is at most risk for atrial fibrillation? What are some of the ways to prevent it? And what is the best strategies and maybe some state-of-the-art strategies to treat atrial fibrillation if it already occurred?
You're just right. Atrial fibrillation is a progressively growing issue. And part of it is age-related. So we know that 4% of the population above the age of 60 may manifest atrial fibrillation. About 15% of the population above the age of 80 may manifest atrial fibrillation. And it makes sense because atrial fibrillation occurs when there are triggers on top of a substrate. So what do we mean by triggers? The triggers would be some extra impulses that bombard the left upper chamber of the heart. And the substrate would mean that the left upper chamber of the heart is not able to shake off those triggers and instead allow those triggers to become sustained in some way. So the triggers can be from a number of things. We know, like you mentioned, a person undergoes heart surgery. Well, there's going to be an irritation in the lining around the heart, and that can cause extra heartbeats. And then if the top chamber of the heart is a little stretched to begin with, and its electrical capabilities are not perfect to begin with, you may perpetuate some atrial fibrillation. Ditto in an area like thoracic surgery. Same thing. Remove a person's lung. That's going to cause a top chamber of the heart on the right side perhaps to stretch a little bit. That could cause the triggers, cause some extra beats. And then if the pumping chamber on the left side, the top chamber of the heart on the left side, is not in perfectly good order, then you may find exactly the same thing. In people who haven't had surgery, we know that if they've just had a history of high blood pressure. So in high blood pressure, the main pumping chamber of the heart on the left side has to work harder. The heart's a muscle. When the muscle works harder, it gets thicker. If you lifted weights, these areas, these muscles would get thicker. Once the muscle's a little thicker, that means the top chamber of the heart has to work harder to squeeze the blood into that chamber. Works harder, so it stretches a little bit. Now, once it's stretched its electrical system. Now you're setting up the substrate so that if there are some extra heartbeats, they may be perpetuated in the form of atrial fibrillation. So the predisposing risk factors for atrial fibrillation, in addition to age, are high blood pressure, and then really anything that may perturb the heart in any way. So valve problems, because they may stretch the chambers as well. Issues with the lining around the heart, the pericardium, because they can irritate the heart. Issues with the lungs can cause it. And then we have a whole bunch of other kinds of things. If the electrolytes are off for some reason, if the thyroid is off. So many, many things can cause it, but you really have to start with there's probably something at least a little amiss if it's going to be sustained. In terms of the anticoagulation, you're just right. That is really our greatest fear in the setting of atrial fibrillation. And the idea is that if the top chamber of the heart is undulating or fibrillating, then a clot may form. And the clot, of course, could break off, and if it travels up, it could cause a stroke. If it travels elsewhere, it could cause an acute infarction or a problem in the bowel. It could cause a problem in the legs, whatever. And the risk of having a clot really depends very much on how stretched that heart is and what a person's risk for clotting is. So there are nicely worked out measures that incorporate the kinds of things that would be important in terms of predicting whether somebody is at a risk for a clot. And just as you'd expect, age is very important. And whether a person is 65 to 75, that's a big deal. If they're above 75, that's an even bigger deal. And as you'd imagine, if they've had high blood pressure because it stretches the heart, that's going to be a big deal. If a person's had heart failure, that's really a big deal because heart failure would imply that there's some problems with the blood in general moving through the heart. Diabetes, we know patients with diabetes have a higher incidence of clotting, so we know that's a big deal. If a person's ever had a stroke, we know that has to be very important because they're telling us something about their blood vessels, their blood clotting, how all of that would react together. So for patients, we can come up, in fact, with a score. Additionally, women seem like they have a higher chance of clotting than men do, especially women when they're above the age of 65. That becomes an issue that we consider. And people with any kind of vascular disease also seem to. So once we have this score, we can determine what a person's risk might be of having a clot, and based on that, can decide should they receive anticoagulants. In the past, there was some discussion that aspirin may have a benefit. But the fact is, if you go back and look at all those studies with aspirin, there was really only one study where aspirin seemed like it was remarkably effective. So we really say aspirin is probably to treat the doctor. It's not really going to treat the patient. So if a person has the risks and you're going to you need to use a blood thinner. The standard is warfarin, Coumadin. It's been around for a long time. It's extremely effective. If you have a patient who is anticoagulated versus a patient who's not, the risk of a stroke can drop down tenfold in the patients who receive the anticoagulation. But you're just right. The way of anticoagulating somebody on warfarin is tough because from the time you adjust the medicine, it's a few days before you see the result. There's always going to be a risk of bleeding, GI bleeding, bleeding under the skin, bleeding in the mouth, and then the most dreaded bleeding, of course, would be bleeding in the head. The newer agents, what we call the novel oral anticoagulants, really represent a terrific breakthrough. And so people don't have to get their blood checked, which is wonderful. Now, on the extremes, so a patient who's very, very thin, probably their levels are going to be too high. Ditto, a patient who's very, very heavy, probably their levels are going to be too high. Patients who are elderly, they probably are going to have more problems than patients who aren't. Patients who have kidney dysfunction, probably we're not going to be so accurate. All of that said, taking into account all the caveats, the beauty of the newer agents is the decrease in bleeding in the head. So every one of the new agents, dabigatran is one, rivaroxaban is one, edoxaban, apixaban, every one of them has a much lower incidence of bleeding in the head. The incidence of bleeding in the head is low to begin with, but these agents seem to decrease it in all the studies before they were released, as well as in post-marketing studies, by a profound amount, maybe by a minimum of 50%, but often 75%. And so that makes all of us feel much better about using them. Sure, we're not happy if somebody has a higher incidence of gastrointestinal bleeding, but if a person hasn't bled into their head and they don't have a stroke, we can usually handle that kind of bleeding and make a real difference.